destroy the other tissues. So fundamentally, cancer is something, a growth which you can't control. So cancers are divided into number of categories. It is called carcinoma, or sarcomas, melanomas, lymphomas, or leukemias. So it is based on where it has been originated. So example, melanoma is a cancer which originates in skin. Similarly, we have a number of cancers. Like if a breast is suffering a cancer, we say it is a CA breast. That means carcinoma of breast. So the clinical classification is based on where it originates. Let's see what is exactly happening in the body if once you are getting a cancer. So we have the proto-oncogenes in our body. So that becomes oncogenes. The proto-oncogenes are not cancerous, but once it becomes oncogenes, it is cancerous. So we have our own mechanism to control such kind of growth. That is a tumor suppressor genes. But unfortunately, if you are getting a cancer, all on a sudden the tumor suppressor genes stop working. That means all our cell cycle, normal cycle fails. So one cell can teach the other cell to become a cancer. So that means cancer is spreading from the origin to different places. Not only on one place, it can go to the entire body. So this is the whole story of a cancer. So getting a tumor doesn't mean that you are getting a cancer. So if you look into clinical, the tumors are divided into two. The one is the benign tumors, other is the malignant tumors. So benign tumors are basically harmless. It's just a big growth, but we can control it. So basically the benign tumors are non-cancerous. If you see the cells, it is capsulated and well differentiated and it can be removed. And mostly it doesn't come back. But in the case of malignant tumors, it is something different. So those tumors are cancerous. And if you see the structures, it is not capsulated. That means the blood supply or oxygen supplies are less. And it is poorly differentiated if you see the structure of a cancer cell. And the biggest problem is that you can't remove it completely. Additionally, this starts invade and damage the neighboring tissues. That means cancer, malignant tumors can metastasize. So that means it can spread. There are two examples I had given. The first one is an amyloblastoma. So that is just a growth in your facial skills. The patient will have an abnormal growth, but it can be managed. But the second one is a typical head and neck cancer. So this growth is not only the cancer. We don't know in the patient where are some other places also the patient can have cancer because it is just visible only on this place. So once you know that you are having a cancer, how to manage it? I think you heard about the treatments of cancers. Fundamentally, there are three methods. One is the surgery. The second one is the chemotherapy, and the third one is the radiotherapy. Surgery means a localized treatment. Surgeon can remove if it is accessible. But the problem is that all tumors are not accessible. So in such kind of situations, you can start trying some drugs. I already told you that the malignant tumors are poorly vasculated. So it's difficult to send a drug to the location where you want. So that becomes a challenge. So the chemotherapy, what we do is that you give drugs to your whole body. So that means if you give a chemo drugs, it has a systemic treatment. It has a systemic impact. That means that your entire system is going to be affected with that drug. Then again comes is the radiotherapy. That is again a localized treatment. Where is your disease? That area you can treat it. So fundamentally, these are the three methods of cancer management. So we say that it's cancer management. I cannot use the word cure for every cancer because every cancer is not curable. Some cancers are curable, some cancers are manageable, some cancers are we can do a remission. That means you will feel like that there is no cancer, but there is cancer. And the Other modalities of the cancer management are hormone therapy or the genetic treatments, or the combined modality is like the combination of the surgery plus chemo plus radiotherapy. I think you must have heard about many patients that the patients first will undergo a surgery, later on a chemo, or vice versa, or followed by a radiotherapy. So currently, the management of cancer is the combination of these three combined modalities: surgery, chemotherapy, or radiotherapy. So, what happens when you're doing a radiotherapy? I'm not going to discuss about what is chemotherapy or surgery. So, if you give some radiation doses to a patient, what will happen? So, basically, it breaks the strands of DNAs. So it can cause single strand breaks. Sometimes it can cause double strand breaks. Sometimes it can damage the bases which constitute the DNA structure. Sometimes it can damage the membrane, or sometimes it can cross-link the DNA structures. I think you are having a basic training in biology, so I'm not going to discuss about the details about DNA and all. So the structure of the DNAs can be altered using radiation. So if you alter the structure of a DNA, the end of the story will be like this. So the some of the cells may not be able to divide it, or some cells will have some aberrations. The chromosome aberrations will be there, or some will change to a different culture itself, like gene mutation can happen. The sequence can get altered, and the end, the cell start dying. So if I change from cell biology to the physics, this is what happens if you give radiations. So any of the interaction can be belongs to any of these three. Either it will be a photoelectric effect, or it will be Compton scattering, or it will be pair production. I think you are aware what is these three effects. These are the fundamental interactions of any photons with any matters. So while these interactions happens, either electron get emitted, or atom will change its structure to another atom. It can emit some energies and become something else. So the radiation physics become radiation chemistry. It leads to some different chemical combinations, results in some biological changes or the biological damages. So in order to say about the radiation, you need to have some fundamental unit. So I'm not going to discuss any of this unit. I think activity is known to you. It is the average number of some spontaneous emissions from a particular atom, or the exposure is a measure of how much radiation you are getting it. So if you get some radiation, doesn't mean that you get some effect. So if you want to get an effect, it needs to change something in the body. So that kind of changes, we will address it in the terms of doses. So exposure is what you receive, dose is what is the end result in your body after receiving some radiation. So before giving some radiation to the patient, you should know what will happen exactly if you give any particular amount of dose to a patient. So how to do that? You cannot expose any human being and see what is happening. You cannot do any clinical trial, or you cannot do any trials like a vaccine trial in a human being. That is not justified using a radiation dose. So such impact of radiations are studied using the biological models. The biological models are the clinical human tissue reactions. Like some people got some problem after interacting with radiations, like a doctor who works in interventional radiology, or a nurse who works in interventional radiology, using an X-ray machine, started developing some particular kind of reactions on a course of time. Yes, you can start correlating that with radiation. Or a very unfortunate event, the Hiroshima attack, the atomic bomb explosion, leads to the death of number of humans. But for us, it's a beneficial incident in terms that we had a lot amount of atomic energy, atomic explosion survivors who can help us in understanding what will happen to a patient if he got some amount of radiation doses. So just see this picture. It's a very important picture. We call them as radium girls, because these girls are basically some workers who works with clocks. So the old days, they are having the clock where they use radium. So they paint the clock using the radium. Sometimes it can emit energy and it will look so attractive. So while they make these clocks, uh, they they use their saliva sometimes in managing some of the minute components. So effectively, the radium start going into their body. So the radium girls started developing so severe side effect later on. We realized that it is due to the radiation. So the overall life history of every radium girl become a tool for us to decide what dose to be given in a patient. So you can appreciate this picture, this graph. This is the therapeutic gain. You can see that in x-axis you have a tumor dose, and another place you have an effect. So the red line shows the tumor control, and this is the normal tissue. So if you get a tumor, doesn't mean that your whole body is tumor. You have a tumor somewhere, and across, around it you have normal tissues. So once you start giving some dose to the tumors, your normal tissue also will start receiving the doses. So the tumor will also die, your normal tissue will also die. But the advantage is that normal tissue can come back to the life. So you need to find a optimum dose such that you have sufficient number of tumor death and the maximum sparing of your normal tissues. So this is the biggest challenge which has been given to a physician who sees the patient uh, for a radiation treatment. So you have to reach in a place where you are managing the both. You control the tumor and you save your normal tissue. So if you decide that I'll give this particular patient a radiotherapy to cure his cancer, so what are the things happening in a department? So I'll tell you what is the radiotherapy treatment workflow that start with the diagnosis. So in the diagnosis, you come to know that this patient got a cancer. So next is followed by the most important, so the patient counseling. So all these procedures are not that easy as you expect. So you need to teach the patient the side effects and what are the complex technical impact you are going to have while the treatment. If they are ready, yes, we will take the patient for treatment. So simulation is the process where you take the baseline information of the patient to uh, to treat using radiation. So then it is followed by the radiation treatment planning. It's a very complex procedure. I'll explain you step by step. So the diagnosis is the place where engineers play a lot amount of roles. I think some of this machine you must have seen in your life. This is a conventional X-ray machine. Yes, this is a Siemens MRI machine. This is an ultrasound machine, and this is a Philips CT scanner, and this is a Siemens PET CT. I think some of these diagnostic machines you must have seen when you visited a hospital or something. This uh, this forms the basis of radiation therapy. You are getting the base diagnostic images, high quality informations to decide what to do. So if you go back to the history, this is the first radiograph which has been captured by the Rontgen. So this picture is also, I think, it is known to you how X-rays are produced in atomic, atomic level. X-rays are produced when the photons are deaccelerated suddenly. So that if you are giving a fast deacceleration of photons, it can emit as a radiation near to the in the vicinity of a nucleus. So the radiation can come out as a bremsstrahlung, or the radiation can come out as a characteristic X-rays. So these X-rays we are using. So once these X-rays pass to a tissue, and once you detect it, you will get a radiograph, something like this. But these days, all these radiograph stories over, you have the high quality of images. I think you must have seen the CT scan or MRI scan of some patients. It will be having some grayscale images. So this is a typical old CT scan. Now, with the advantage of the advent of the technologies, you can have so much number of additional facilities you are getting. You just remember this was the scan which you have started using, and now you are end up in a place like this. Once a PET CT machine comes to the market, you can see that how much uh, functional your image is. So what they have done, they put some radionuclide and they place some detectors in your CT scanner. I think you can see this one. This is an CT machine and this is a PET CT part. Means it detects the radiation. First part, take the image, the lower portion, take the functional image. So once you mix it up, you can see the differential attenuation in the body. So we can appreciate how much part of the brain is receiving the uh, radionuclide because it is being taken by the body and it is targeted. So we inject the substance such a way that the tumor cells will take it because we inject the things which the tumor likes. So by seeing this picture, you will be able to appreciate that this patient is having some problems in the liver, and the patient is having a node which is in the shoulder, and there is some uptake in the brain. So a blind CT will not give you any of this information. So you can appreciate few nodules in the liver, but not the entire nodules. So the similar story is that the second one is a PET MRI. So you add the functional images to an MRI. So the result, you are started getting more informations. So so in the result, you can identify the more number of nodules. So these are the images, the PET CTs or the PET MRI or the CT or MRI give you the information of the disease. So now the first part is to know your disease. So by diagnostic machines or the diagnostics tools, you will come to know that what is your disease. So the most important part of a radiation therapy is the contouring on a CT scan or an MRI scan, which is going to use for a planning. So a doctor has to contour a GTV, CTV, PTV, or ITV, OIR, followed by some help structures. So GTV is your disease. So CTV is a disease plus some extra distance you are going to draw. Why? Because you may miss something because everything is not visible in your diagnostic images because every images or technology has its own limitation or its own least count or resolution. So all your disease may not be visible. So if you have a core disease, you add some microscopical length to make it as a CTV. So, and you are going to treat the patient. So, while you place the patient in your machine, it may not be the same way you must have placed in the diagnostic machine. So, you will have some setup uncertainties in order to compensate that all misses. You add some another margin. So, you are going to draw a PTV. So, what you are going to treat is a PTV. So, by treating a large margin, you are making sure that your disease is not missed. So if you see this particular scans, this is the patient having a CA right breast. So we can see that where is the disease. I'll tell you the actual disease of this patient is somewhere here. So the patient is having somewhere disease here. There are as nodules. That is called a tumor bed. But the doctor contoured this much entire region as PTV because just to save the entire breast, they have not removed the breast through the surgeries. Instead, we are going to treat using the radiations. So in addition to that, they have contoured the right lung, left lung, the heart, other structures, the nodes and all in the shoulder. So we have contoured a lot number of structures in order to treat this patient. So why? Because I just want to know what are the doses to each number of organs such that I can limit the doses to the other part that they remains good and the tumor remains dead. So now you know what to treat, where to treat, what to save. Now the biggest question, how to which energy you will choose to treat a patient. So in front of you there are a number of options. Basically, if you see that a 20 MeV electron beam is there, then the X-rays are there. It's a 15 MeV X-rays. This is the 15 MeV X-rays, and you have the protons. So if you check the electron, so after 10 centimeter of the depth, the dose is almost 10% of the initial dose. That means electron cannot do anything in a depth, but it can do well good if your depth is very less. So if your tumor is very close to your skin, so we can use electrons. So you can choose any of the electron energy as per the dose deposition nature. But if deep seated tumor is there, then you cannot use your electrons. So then uh, you are with the two remaining options. That is, one is the X-rays or the protons. So you can see that X-ray is having a, so if you see, go to the 30 centimeter depth, X-ray still deposit 40% of the initial dose. That means I can still use X-ray to put some amount of dose in the depth. And the best is a proton. So you can see that proton, what happens is that it start going and it deposit at a particular depth. So it deposit at 25 centimeter depth. So if you manipulate the energy of these protons, so you can deposit whatever energy you want at wherever you wish, and the rest of these areas will have very minimal dose. So the best energy is proton. The biggest problem is the practical availability of proton is very challenging, and it is so complex. So on a daily basis, you cannot reproduce the proton energies. So we end up with X-rays. So X-rays are the best solution to treat the patient. So how to get an X-ray or a gamma? So the X-rays are produced in the vicinity of the nucleus. The gammas are produced inside a radionuclide. So either you can use a radionuclide or you can use X-rays. So these are some old images. The first is the way they treat a patient using radium. So these two images of radium. Sorry, the second image is of a cesium. First one is of a radium. And the third one is a cobalt 60. And sorry, I made a mistake. This is again radium. This is cesium. So they are using three different radionuclides. These are some old technology where they use radionuclides like radium, cesium, cobalt, or iridium to treat the patients. This is challenging because it's a radioactive material. You need to have very sophisticated safety mechanism to make sure that radiation is safely delivering. It is not giving any harm to anyone who handles it. So it is very tough. And other thing is that these radionuclides, it will um, yeah, as the days goes ahead, it will change to other radionuclides by emitting the radiations like alpha, beta, and gamma. So the end products are not good always, and sometimes the end product, like if you keep a radium, so after few days you will start getting the redundant gas. The redundant gas is very poisonous, so you are getting additional challenges if you have radionuclides. So this is such a beautiful picture. These two people are really great. The first person is the Henry Kaplan. He's a physician at Stanford University. So one day he was quite bored with the side effects of the patient, which he treated using the radionuclides. He was quite unhappy for those incidences. While he was going through the literature, he come to know that the physicist or the other scientists are using something called a linear accelerators. So what he does is that he went to Stanford University. He went and met the physicist named Michelle Wilsberth, and they discussed. And they have done together is that they used a a laboratory linear accelerator to a patient. The results were really surprising. This is one of the very beautiful picture. This is the infant. This particular infant got the first time treatment from a linear accelerator. This kid is having a tumor in his eye. He got a retinoblastoma. He got cured using the first linear accelerator treatment. This was such a huge achievement. And the second picture is one of the routine patient in the Stanford University. So now radiotherapy means a linear accelerator. Henry Kaplan changed the every story. So the laboratory or the nuclear reactors, the linear accelerators, come into the clinic. So we call them as the medical linear accelerators. I think you guys will be knowing much better than me. So linear accelerators, as its name indicates, is accelerate the charged particles. Here we accelerate electrons. So you can accelerate electrons and you can put a target like a tungsten, such that these electron beams are getting a sudden deacceleration. So the charged particles, when they get a sudden deacceleration, they change to photons. They either emit X-rays or they emit characteristic X-rays. So these electrons hitting a target and they're taking out that X-rays can be used for a patient. So here it has an acceleration. If you see a medical linear accelerators, so every electronic structure will be here. It accelerates, and the end product X-ray will come down here. The patient will be here, so the we can direct the radiation beam to the patient wherever you like it. So this is what we does on clinic these days. This is what radiation oncology. So radiation oncology, the treatments are classified into two. The first one is the external beam radiation therapy. The second one is the brachytherapy. So as name indicates, external beam radiation therapy means source is outside the body. So the brachytherapy means source is inside the body. Source is outside and source is inside. In these two techniques itself, there are a number of subspecialties. So external beam radiation therapy, we have conventional 3D CRTs, MRTs, IGRTs, SBRTs, etc. So if you go to brachytherapy, we have interstitial intercavitary resurface mode like that. So I'll tell you what is a conventional radiation therapy. So the conventional radiation therapy is the conventional methods which we have used, or this is the methods where we use to treat the patients which is having a palliative intent. Like sometimes we will have patients which doesn't have any hope of future life, like the patient may expire in a week time or in a month's time. So we need to control their pain. So that is called a palliation. So if you want to control the pain and your intention is nothing else, you are not bothered about any of your normal tissues. So you're not going to worry about the reactions the patient is getting. Then if you want to give an immediate treatment, you can go with a conventional method. So in conventional method, you can see that this is the disease. This particular patient is having disease in both lungs. So this patient is having 2 lung tumors. What they have done, they put a lateral beam to capture the right-sided tumor. They put another lateral beam from the left side of the patient, and they kept 2 posterior beams. That means if you give this kind of beams, if you give this amount of radiation, so these overlapping regions almost this much, and here it is almost this much. So this much area is going to get very heavy doses. Not only that, this dose will continue here, some amount of doses. This will be here also. This will be here also. That means just to control 2 minor tumors, you are exposing more than the half of that patient body in that region. So this is called a conventional technique. So the second image is a patient having a spine tumor. The tumor is little posterior in nature. So what they have done, it is quite bigger. So they put 1 posterior beam, 1 anterior beam, such that the patient is getting a dose throughout this area. We are not worried what the heart is getting and the other lungs are getting, because our intention is just to control the pain. This is not the story always, because all our patients, most of our patients are not palliative. They are coming with a curative intent. So we don't need to expose more number of the body areas. So such kind of situations, we use a 3D CRT technique, 3-dimensional conformal radiation therapy. So you can see that the patient is having some gynecological cancers or the pelvic tumors. So we kept a field number 1, you kept a field number 2, 3, and 4. And you can see that they have kept something else also. That is called a wedge. Wedge is something which attenuates radiation which before it goes to the body. So it has some attenuated beams. It has multiple number of beams such that the most important dose will come to the area where it overlaps. Still, the other areas will get a doses, but it will be much, much lesser. So you start conforming the radiation doses to the place where you want. So this is a technique which has been widely used across our country. It is cheap in nature. It doesn't take much time to plan. But sometimes you will have patients where there is a good amount of chance that patient will leave. So such kind of patients, you have to go very specific. That means I just want to treat my patient where there is only a disease. So that is possible only why? Because of a great engineering technology. We call that equipment is called the multi-leaf collimator. Multi-leaf collimator is an equipment. It is not an equipment. It is an I can say that it is an attenuator which is placing in a linear accelerator such that the beam which has been coming out from a machine is getting the shape of a tumor. If you see the center of these MLCs, you can see the tumor shape. So you started exposing the patients where in the shape of the tumor itself. So if you do such kind of an intensity modulator radiotherapy, your patient will have only the doses where his disease is. You can see that tumor is there and there are diseases. If you see the fields, you can see that here beams are open. It is a straight line. So we can see that here the disease is having some wave shape. That means they are saying that they placed some kind of MLCs such that these MLCs will help to get a
Hello,
very
sir.
nice. Hi.
Sir, I think your presentation has been stopped.
Presentation is stopped.
Yeah, could you
Hello.
please restart it again? It isn't visible. Could you please restart the presentation again?
Is it visible now?
Not yet.
For how long it is happening?
I guess for a few minutes.
So one sec. I don't know what happened. Is it visible now?
So could you just go back and stop the presentation for a minute and just restart it? Yeah, now it is.
You're
Yeah,
getting
now
it?
it is visible.
I'm very sorry
Yeah,
for
it is
such an
visible right
incident.
now.
I don't know what happened. So you want to start some from a previous slide?
So it is
So I
okay.
this you
It is
got
fine
this.
from here.
This you got this one.
Yes, sir.
Okay, so this screen, so this is a multi-leaf collimator. So this is a multi-leaf collimator. If you see the shape of a multi-leaf collimator, you can see that it is having the shape of a tumor. So if you see the beams, you can see that a waveform. That means your beams are having MLCs in those directions. So the end of the story is that your radiation is just focused on your tumor. So this is the best technology, the more advanced technology of an IMRT, or it's an extension of the IMRT. So the companies come up with a solution where the linear accelerators can rotate the way any way we want. So this Lina can rotate in 360 degrees such that I can rotate it and treat my patient. So if you see this patient, the first one is an IMRT. So you have some fixed directions and you use the MLC and get a shape. And the other cases, you are going to treat the patient using an arc. Still, you use an MLC. So you will get more and more beautiful dose distribution such that all your organs are quite safe. You can appreciate that this is the disease and doses across that. And very less amount of dose is there to the other part of the normal tissues. So and now even we have the technology called the image guided radiotherapy. Every day you can check how good is your patient is reproduced on a couch. So this particular image is a screenshot in a linear accelerator. So you can see that this is the reference position of the patient. So this is the image of the day today, and this is what it was yesterday. You can see that the bones are quite matching, but not the best. Here also you can see that the bonds are not matching exactly. So what happens is that once you start getting the radiations, the patients start getting some effects such that their weight has been reduced, or sometimes weight has been increased, or any other changes will result in a different positions. So in order to overcome that, the engineers comes up with a solution called the image guided radiotherapy. So what they have done, they put some arms in the linear accelerator. These are the arms. This produce diagnostic X-rays and check the image position whether it is correct or not. So even you can do the radio surgeries. You have a technology called cyber knife. This is a cyber knife machine. So you can see that a very small openings. So if you very strictly immobilize your patient, you can put any heavy amount of radiation doses to the body such that it is equivalent to a surgery. So such a typical example is given the radio surgery. So this is you can see the before the patient is having such a long tumor. So once you start giving a very heavy amount of radiation doses, in few days the disease become like this. So on a course of time, this particular patient will get cured. So such radio surgeries are possible only with the engineer. Uh, this is everything today. The proton therapy, we can see how beautiful this picture is. The patient is having a tumor in the left temporal lobe. So this is the dose. And once you give a proton beam, it's a single beam. As I said in the earlier in a graph, proton can stop at any place wherever you like it. So the beam went and stopped where I want. So there is no exit dose, no exit doses, no spillage to any part of the body. The doses is only to the area where you want. So the second picture is one of the proton therapy machine, which is in which is in US. But the challenge about the proton is the heavy amount of cost. Each single treatment, a patient maybe need to submit around 45, 55 lakhs to get treated. I don't think that most of us will be able to afford such a cost. Even the insurance companies may not cover it to that level. But still, if a patient is able to take a cost of that number of lakhs, and they will get a cure. So why, due to this cost, this is not very popular in India. Only two centers are having the proton therapy. That is, one is Apollo Chennai, and other one is my center. So I'm going to brachytherapy. I am sure that this picture is going to irritate you in some way. This is the treatment. This is one of the best treatment I can give to my patient. You are going to place the radiation sources in the patient body itself. You are not going to use any linear accelerators. So if you are placing your radiation sources inside the body or the body cavities, it is called a brachytherapy. So the brachytherapy we generally do using iridium or a cobalt. The best advantage is that it have a heavy dose follow-up such that the tumor is getting the dose. Once the radiation source goes inside, it will stay back for some time, which the physicists decide, and it will come outside. So that particular portion of the body will get the radiation doses. The first patient is a CA tank. So we have inserted some catheters, and we will send to the radiation source through these catheters, and it will reach on the tongue, and it will stay for some time, and it will irradiate, and it will come back. Once you complete the radiation course, you will remove all these catheters. The second one is a CA breast. It is called accelerated partial breast irradiation. So you have a disease. This is the actual disease area inside. You remove the lump from the patient, and still you put some needles such that whatever remaining there will be treated. So this will be done with the help of a surgeon, a physician, physicist. And the third one is a penile cancer. The same story. You are putting the needles and you are treating the disease, and you're removing it. The most important thing about this thing is that the patient is going to get his organ back. This patient can go back and having a life with her tongue. the patient will have the breast back, this guy will have the penis back, because they can lead their life without having any inferior quality. So the brachytherapy is done using a machine like this. This is a great achievement from the engineers. They come up with a solution that a radiation source can go as per our command. So this particular technology is connecting to a machine. So this tube will go through the nose and it will go through the esophagus, and in the end it will reach on his stomach. Wherever the esophageal tumor is there, maybe the patient may have tumor somewhere here, and they will be able to treat it. So, in addition to this, there are many technical things are there in radiation therapy that I cannot um, cover everything is here there, but I will introduce few things. So, this black and white picture, this was the duty of a physicist some years before. He doesn't have any. Sorry. So there doesn't have any method of seeing any dose, because you don't have any sophisticated computer systems which can predict the radiation doses. So they used to draw in an oil paper using a radiograph the doses which you want. But what it is today is this. This is because of the great advance in the technologies. So now we have so many dose calculation engines. That is the contribution of the computer science engineers. They come up with the solutions to calculate the best, to predict the behavior of the radiation rays. So there are many commercially available solutions from these companies. So they provide different methods of calculation. Those are called algorithms. They are classified into different algorithm based on how they predict the nature of the radiation beam. So once it comes to the quality assurance and the control, the quality assurance, by getting a technology doesn't mean that you achieved everything. So if you are able to maintain the quality, or if you are able to maintain the performance, then only it is valid. So there are a number of recommendations to make sure that your radiation doses are delivering correctly. There are a number of tools. So those all are the engineering advantages. So these are the anthropomorphic phantoms which has been created uh, using many complex materials, so that help us to do trial runs and dummy runs. So this is an Octavius which has been designed by the PTW company. It helps us to verify the patient doses. This is a phantom called the Dolphin Phantom, which helps us to predict some radiation doses. So these are the radiation detectors. As you know that you cannot sense radiation, so you need to have complex instruments to predict the radiation doses. This is a GM counter. This is an ion chamber. This is a survey meter. I think if you watch the Chernobyl series, you must have seen the physicists are using this detectors. So, engineers play the most important role while establishing a radiation facilities. So, while establishing the baseline parameters of the data for using a linear accelerators, the engineers' help and support is it's very important. They help us in generating all the data. The same way to decommission or to save disposal of radiation waste, the biomedical engineers plays a very huge important role. So if you see this, it's a busy slide. Basically, this tells you what is the radiation dose to the staff who are handling all this, like the physicist, physician, nurses, the technologist, or the biomedical engineers. So you can see that the dose is 0.28. So due to any incidences, any unexpected incidences, so till that incidence is also there, they are getting up to 0.81 millisievert. So I will tell you how simple these doses are. Don't think that the staffs are getting any heavy amount of radiation doses. Just to give you an idea, I will tell you what is the radiation dose in Kerala. So this study is from the RCC. So the radiation dose in the Katanagapalli area is somewhere around 4 millisievert. So our radiation staff is getting around 0.28, but the Keralites are getting almost 15 times higher dose from the background radiation itself. By staying in Kerala itself, you are getting almost 15 times than a radiation worker. That means we both are safe. We don't need to worry about that. Even if 4 millisievert doesn't cause any any impact in our body. I'm telling that all these people are very safe because of the great technologies. So after this day's presentation, I want you guys to go back and see some literature. There are many great organizations where you can get information about how important an engineer in medicine. You can go back to the website of the AAPM, like the American Association of the Physicists in Medicine, or you can go to IPM, the Institute of Physics and Engineering in Medicine, or AMP or IAA, like that. So, while concluding, I want you guys to go back to the literature and read this particular literature. This has been published with a title called Engineering and Physical Sciences in Oncology. What are the challenges? What are the opportunities in management of the cancer? So you will come to know that what are the areas where you can contribute in cancer management. I wish to mention one particular incident in 2007. I spent almost 6 days in the boys' hostel of your St. Joseph's College. I come to Mar Augustina's College for a program, and I stayed here, and I feel still have that warmth and hospitality which I got from your college, and I'm feeling so proud. And this is such a beautiful evening. All the programs were of very high quality, and I congratulate each one of you, the engineers. The engineers is such a great profession, and I wish you all the best. And I'm congratulating each one of you for this great initiative. And also expressing my thanks to Anna and Timothy for the excellent coordination. If you have any doubt, you can ask.
Thank you so much, sir, for the amazing session. If is there anyone having any doubts? ചാറ്റ് ബോക്സിൽ ആർക്കെങ്കിലും ഡൗട്ട് ഉണ്ടെങ്കിൽ ഒന്ന് മെസ്സേജ് ഇട്ടാൽ മതി. Sir, there was a doubt that does radiation shorten your life?
Radiation?
Shorten your life. Does radiation shorten your life?
You want to know in terms of a patient, or you want to know about a staff?
Sorry, sir?
So you are asking me that whether radiation shortens our life span. So I just want to tell you that one first thing about the patient. So you don't need to consider about the patient because you are giving radiation to the patient for the benefit. So it extends the life of a patient. Regarding a staff, I say no. Why? Because you guys are the reason. We have such a great technology such that nobody is getting any extra doses. So why? I think you remember the table which I shown you, that the radiation doses which is received by any staff, even it is lesser than your background radiations. That means it's due to such a great technology. If you come to any clinic, or if you come to my clinic, I will show you how great the technologies are. You are not going to get anything. There is no way for that. So what are the precautions taken by the radiotherapist while treatment? Yes, there are some precautions.
Radiotherapist while working with radiation.
So the radiotherapist fundamentally is a radiation.
Sir, your audio was breaking.
Hello, is it audible now? Hello? And is it audible?
Yes, sir. Yes, sir.
Okay. So the precautions are already taken. Why I am saying that is called the design of a radiation installation. So we design a radiation installation in a way that there are a minimal propagation of radiation through those walls, such that wherever the staffs are sitting, there is equivalent to the safe radiation limits. So there are some safe radiation limit which has been set by IAEA. That anyone can receive it. So that is the amount of radiation where these staffs are working. And other than that, if we take more precautions and we regularly observing the radiation doses of these people by using a TLD, that is a thermoluminescent dosimeters, that is they are wearing it. So by wearing it, the TLDs, we regularly check it, and we will see that there are very less radiation. There are less radiation doses to that. There is no way, because your technology is that good. Also, if a lady staff who is working there turns pregnant, we won't give any radiation works and all, such that she is not even getting any background radiation level. And some other questions were there. 1 minute, I'll just see the questions.
So next question is, how can
Is
we
the
reduce the
per-
possibility of cancer
that I'll
in
tell.
our daily life?
Is permanent implants of brachytherapy harmful? I want to tell you that it is not a permanent implant. Very most of the brachytherapy implants are not permanent. That we will remove it, and there are some permanent implants that we typically use for the prostate cases and all. It is not harmful. I just want to tell you that the patients who carries the permanent implants are good for them because it will cure their cancer and it doesn't cause anything serious to the other organs. So why we placed it over there? That area is so good enough that there is no impact. How can we reduce the possibility of a cancer in our daily lives or after treatment of cancer? After what are the side effects? Okay, so to reduce the possibility of a cancer in our daily life, I'm not a good physician to tell on that. I'm a physicist, but still I will tell you few things. Be strict towards your natural things which is available with you, because you must be remembering in my presentation beginning I shown you that these are some genetic variation of the DNA changes or the cell changes which is happening. So the cell changes are started by some kind of stimulus. That stimulus can be anything in nature, one chemical in your body, or some genes which you are carrying from your parents. So or anything, some incidents or some climatic changes. So this can cause stimulate something on a patient. It does not valid for everyone. Like we two are getting a rain. Maybe tonight I may get a fever, you may not get it, because it is the way the body responds to that. So you can be as good as natural it is, then you can reduce it. There are some there's certain things like smoking or the tobaccos or the alcohols, which all leads to the cancers. You can control the amount of such consumptions. So there are some side effects.
എക്സ്ക്യൂസ് മീ സർ.
Okay.
എക്സ്ക്യൂസ് മീ സർ. എല്ലാവർക്കും ഫീഡ്ബാക്ക് ഫോം ഞങ്ങൾ ഉടനെ തന്നെ ഞങ്ങളിപ്പം നമ്മുടെ ചാറ്റ് ബോക്സിൽ ഇട്ടിട്ടുണ്ട്. യൂട്യൂബിൽ ലൈവ് കാണുന്നവർക്കും ഫീഡ്ബാക്ക് ഫോം അവിടെ അവൈലബിൾ ആയിരിക്കും. അപ്പൊ നിങ്ങൾ അത് ഫില്ല് ചെയ്യണം. ഫില്ല് ചെയ്തവർക്ക് സർട്ടിഫിക്കറ്റ് ഇന്ന് തന്നെ കിട്ടുന്നതായിരിക്കും. സോ
Okay, I think time is also exceeding, but I will finish in few words. So there are side effects, but there are methods of managing that side effects because we have to compromise on something to get a good benefit. So the side effects are temporary. If you give a good social, mental, and the other care, the side effects can be managed. There is no worries regarding that. If someone of your home is suffering from a cancer and getting a side effects from the treatment, don't worry for that. It will go in course of time. So potential lethal cancers can be spotted. Yes, you can spot some of the cancers by a regular follow-ups, regular health checkups, or how good you are reporting your problems to your physician. So how good you are taking care of your body is the fundamental thing. You just check your bodies. If you're feeling something unusual, you can report to your physician. So most of the unusual things will be nothing. So such kind of regular checkups of your own body, or regular hospital visits can predict some of the cancers, because some of the side effects which is in the body can predict that something is coming in the behind. So nanotechnology in cancer treatment. So surgery is a method to cure cancer, but after surgery, cancer we will know cancer is cured. So surgery is a good method. The nanotechnology is yes, it is not yet established too much in cancer therapy. It's just there are some impacts, but it is not widely practiced because it doesn't come up with good solutions. It is, but it can. The future we can expect though. So after a surgery. How we'll know that cancer is cured? So, in a typical example is that imagine that this particular patient is having a PET CT before the surgery. You can take a PET CT afterwards. You can check it. How is the intake, and you can feel that the intake is very less. Then you can predict that many things are surgically removed. So, in additionally, what we do when we do a surgery, just followed by that, we use some radiation doses or a chemo drugs to kill the microscopic tumors where a surgeon failed to remove. Yes, any other doubt?
Sir, there was a question from the YouTube live.
Okay.
The question is that what is the use of nanotechnology in cancer treatment?
Yeah. The nanotechnologies, the resources are there. So basically, the nanotechnologies can target something, but in our daily practices, this is not yet started. Why? Because this all requires extensive clinical trials. Later on, only it will come to us. The resources are there to target. So I can say that there are. It will come in the future. Nanotechnologies can go and sit where the cancer tumor cells, not everywhere. So at least some of the site, I can expect that nanotechnology can do something, but that will be in the future. What about the scope of MRI compatible neurosurgeries? MRI compatible neurosurgeries are great. Such a beautiful question, such a brilliant question. So, if we are able to use MRI, because MRI is one of the gold standard imaging, everywhere we are not able to put an MRI linac. Why? Because see, if you think about a surgery, you have so many metallic tools will be there. So, but if you have an MRI machine, so it's a magnet. So magnet attracts many of these metallic things. So you need to have everything which is MRI compatible. So that is tough if you consider in terms of the other surgeries. So you need to have a balance. So the balance is tough to achieve, but it's such a great question you have asked. It can do a lot if we get all that MRI compatible tools in a surgery room. That is difficult, but anything else?
Is there anything else?
I think no. I think I took 1 hour.
I guess it's time, sir. So
thank you so much.
Thank you so much, sir, for such an amazing session. After talking of our love from the SJCET NSS Unit 201 and 564, we are presenting you a virtual memento. It will be presented in the screen.
Thank you so much, all your great messages and appreciation. I will be very happy.
Sir, could you just wait for a second? There is a network issue that it will be presented.
I don't mind. Your words are more than enough for me. Thanks a lot.
So there is a vote of thanks section for you.
Yes.
So I invite Mr. M.L. George to say a few words and a vote of thanks to you.
മനസ്സിലാവട്ടെ. ഇന്ന് നമുക്ക് ഈ ഒരു മണിക്കൂർ സമയം റോൾ ഓഫ് ഫിസിക്സ് ആൻഡ് എഞ്ചിനീയറിംഗ് ഇൻ ക്യാൻസർ മാനേജ്മെന്റ് എന്ന വിഷയത്തെക്കുറിച്ച് വളരെ മനോഹരമായ ഒരു വെബിനാർ സെഷൻ നൽകിയത് ഗവൺമെന്റ് ഓഫ് ഇന്ത്യയുടെ അറ്റോമിക് എനർജി ഡിപ്പാർട്ട്മെന്റ് മെഡിക്കൽ ഫിസിക്സ് സയന്റിഫിക് ഓഫീസറായി പ്രവർത്തിക്കുന്ന പ്രിയപ്പെട്ട ലിബിൻസ് കറിയ സാറാണ്. സാറിന്റെ ഈ സെഷനുടനീളം സാർ സംസാരിച്ചതും പങ്കുവച്ചതുമായ കാര്യങ്ങൾ ക്യാൻസർ എന്ന രോഗത്തെക്കുറിച്ചും എങ്ങനെ ക്യാൻസറിനെ പ്രതിരോധിക്കാമെന്നും അതുപോലെ തന്നെ ഫിസിക്സ് എഞ്ചിനീയറിംഗ് സാധ്യതകൾ ഉപയോഗിച്ച് ക്യാൻസർ രോഗത്തെ എങ്ങനെ മാനേജ് ചെയ്യാമെന്ന് മനസ്സിലാക്കാൻ സഹായിച്ചു എന്ന് ഞാൻ കരുതുന്നു. സാറിന്റെ തീർപ്പുകൾക്കിടയിലും നമുക്ക് വേണ്ടി ഈ സമയം മാറ്റിവെച്ചതിലും വളരെ ഫലപ്രദമായ ഈ സെഷൻ നൽകിയതിനും ലിബിൻ സാറിനോടുള്ള നന്ദിയും സ്നേഹവും SJCET NSS യൂണിറ്റിന്റെ പേരിലും അതുപോലെ തന്നെ ഈ സെഷനിൽ പങ്കെടുത്ത എല്ലാവരുടെയും പേരിലും ഈ അവസരത്തിൽ അറിയിക്കുന്നു. ഭാവിയിലും സാറിന് ഉന്നത വിജയങ്ങളും നേട്ടങ്ങളും കൈവരിക്കാൻ സാധിക്കട്ടെ എന്ന് ആശംസിക്കുന്നു. അതുപോലെ തന്നെ ഈ പരിപാടിയിൽ പങ്കെടുക്കുകയും ഈ പരിപാടി നടത്തുവാനായിട്ട് വേണ്ട സഹായങ്ങളും സപ്പോർട്ടും മാർഗനിർദ്ദേശങ്ങളും നൽകിയ ഞങ്ങളുടെ ജോയ് സാർ, ആൻഡോ സാർ, EC HOD ദേവസ്യ സാർ, CS HOD ജ്യോതി സാർ എന്നിവരോടുള്ള നന്ദിയും സ്നേഹവും അറിയിക്കുന്നു. അതുപോലെ തന്നെ ഈ വെബിനാർ നമുക്ക് വേണ്ടി ഇത്ര മനോഹരമായി ഒരുക്കി തന്ന ഞങ്ങളുടെ VSമാരായ ആകാശ ചേട്ടൻ, തിമോത്തി ചേട്ടൻ, നീരു ചേച്ചി, ഇവ ചേച്ചി എന്നിവരോടുള്ള നന്ദിയും സ്നേഹവും ഈ അവസരത്തിൽ അറിയിച്ചുകൊണ്ട് നിർത്തുന്നു. നന്ദി.
ആരും പോകരുത്. നേരത്തെ ഒരു നെറ്റ്വർക്ക് ഇഷ്യൂ കാരണം ഞങ്ങൾ ഡിലേ ആക്കിയ ഒരു ഈവെന്റിന്റെ ഒരു വീഡിയോ റിലീസ് കൂടെ ഉണ്ട്. കോവിഡിന്റെ പരിമിതികളിൽ നിന്നുകൊണ്ട് ഞങ്ങളുടെ കുറച്ച് NSS വോളണ്ടിയർമാർ ഇന്ന് നാഷണൽ ക്യാൻസർ അവയർനെസ് ഡേയോടനുബന്ധിച്ച് ഒരു ക്യാൻസർ അവയർനെസ് വീഡിയോ ഉണ്ടാക്കിയിട്ടുണ്ട്. അത് നിങ്ങളെ എല്ലാവരും ഒന്ന് കാണിക്കണം. എല്ലാവരും ആരും പോകരുത്.
ജസ്റ്റ് അതിനു മുമ്പ് ഒരു കാര്യം പറഞ്ഞോട്ടെ. നാളെ നമ്മളുടെ NSS SJCETയുടെ ഇൻസ്റ്റഗ്രാം പേജില് സിംഗർ അരുണിമ വേണുഗോപാലിന്റെ ഒരു സന്ധ്യ ഉണ്ടായിരിക്കുന്നതായിരിക്കും. എല്ലാവരും അതിൽ വരണം. ബാക്കി ഡീറ്റെയിൽസ് ഒക്കെ നിങ്ങളുടെ VSമാരെ ഞങ്ങൾ അറിയിക്കുന്നതായിരിക്കും. അപ്പൊ മാക്സിമം എല്ലാവരും ഇൻസ്റ്റഗ്രാമിൽ ലൈവില് വരാനായിട്ട് നോക്കുക. താങ്ക് യു. ഓക്കെ.
നിങ്ങൾ പ്രാർത്ഥിക്കുമ്പോൾ നിങ്ങൾക്ക് വിശ്വാസമുണ്ടോ അത് സഫലമാകുമെന്ന്? ഓരോ തവണയും നിങ്ങൾ ഭാഗ്യം പരീക്ഷിക്കുമ്പോൾ നിങ്ങൾക്ക് ഉറപ്പുണ്ടോ വിജയിക്കുമെന്ന്? നിങ്ങളിത് എപ്പോഴെല്ലാം ഉപയോഗിച്ചാലും ഒരു കാര്യം നിശ്ചയമാണ്, വായ്ക്കുള്ളിൽ അറുപ്പ്. ഭാരതത്തിൽ തന്നെ ദിവസേന 3500 പേർ തമ്പാക്ക് ഉപയോഗിക്കുന്നതിലൂടെ മരണമടയും. ഇവയിൽ 3000 പേരുടെയും മരണകാരണം വായ്ക്കുള്ളിലെ അർബുദമാണ്.
മെറാക്കി അത് ഇപ്പോൾ ഇന്ന് തൊട്ട് ആരംഭിച്ചിരിക്കുന്നു. എല്ലാ മത്സരാർത്ഥികൾക്കും NSS യൂണിറ്റ് 201 and 564 ആശംസകൾ നേരുന്നു. മീറ്റിംഗിലും വെബിനാറിലും പങ്കെടുത്ത എല്ലാവർക്കും ഒരിക്കൽ കൂടി നന്ദി രേഖപ്പെടുത്തുന്നു. താങ്ക് യു സോ മച്ച്.
ഫീഡ്ബാക്ക് ഫോം കിട്ടാത്ത ആരെങ്കിലും ഉണ്ടെങ്കിൽ വെയിറ്റ് ചെയ്യണേ. ഞങ്ങൾ ഒന്നുകൂടെ ഫീഡ്ബാക്ക് ഫോം ഇടാവോ?
തിമോത്തി, നമ്മുടെ പ്രോഗ്രാം എല്ലാം റെക്കോർഡ് അല്ലേ?
റെക്കോർഡാ സർ.
ഓക്കെ മോനെ. ഓക്കെ താങ്ക് യു ഓൾ. ബൈ.
താങ്ക് യു സർ.
താങ്ക് യു സർ.
ഓക്കെ.